just a total of participants, and we're going to try to keep.
The panel's chair. We'll just go around and make sure everybody knows who each other are.
Sarah Lopez, County Commissioner for the 2nd District.
Senator Yusha Reddy for District 22.
I'm Jason Gregory. I'm with Downtown Wichita and Greater Wichita Partnership.
I'm Tom Stolz. I'm Sedgwick County Manager.
Mark Bennett, District Attorney, Sedgwick County.
Jeff Easter with the Sedgwick County Sheriff's Office.
Claudio Ferraro, President of St. Joe Hospital.
Mary Jones, Mental Health Association of South Central Kansas.
Will Carpenter, House District 75.
Joan Tammany, ComCare.
Thank you. We've got name cards so we can call each other by name as we need to. And you've got an agenda in front of you and some other materials at your place that we'll walk through. There is a set of minutes from our last meeting. I'll give you a couple of minutes to take a look at. The one thing that I did want to note, I think that we added to the minutes after we reviewed them internally end of last week. Senator Reddy had asked a question at our last meeting about state institutional alternatives and how much KDADS had been spending and what the average rate was. We didn't get that into the minutes. So on the second page there at the bottom, we did add that to the minutes. In 2024, our projected spend is $10.4 million. And our rate is the average rate is $1,170 per patient day. For the 9 hospitals that participate. But everything else is a summary of what we talked about the last time. Are there any corrections, additions, deletions to the minutes, Joan?
Scott, I do. Oh, I'm sorry. Go ahead, Joan.
I will here in just a second, but if Sheriff, you had a
On
change.
the last page here under 8, and it's the 8th paragraph where it talks about, I indicated there are currently 26. Longest has been waiting 186 days. That 186 days is incorrect. It's 467 days. I just ask that we make that change, please.
We'll make that change. Any other corrections? With that change, is there a motion to approve minutes?
Second.
Moved and seconded. Any objections to approving the minutes? Hearing none. With that correction, we'll put those into the record. So our plan for today is a couple of rounds of updates from where we were the last time that we met. Wanted to talk a little bit about the current state hospitals that treat mentally ill patients. So we've got the 2 superintendents on the call, and they'll do a presentation. And then I asked if the county could give us an update on mental health programming in the county and how that's changing and how we would fit. So several different levels of updates, and then some discussion about our future meetings. But I get to go first. So since the last time we met, we've been working on minutes and just kind of moving the project forward based on where we talked about last time. One thing we have, and I think I mentioned it the last time, we've engaged a contractor to help us with public outreach and managing these meetings and working on the final report. And when we met last, the contract wasn't quite executed, so I couldn't talk too much about that, but that's all transpired now. So the Learning Tree Institute at Greenbush is who we're working with for helping us gather public input, organize these meetings, and of course, work on the report. And that team is represented here today, and we'll have Monica come up and make a few comments and introduce herself and the team. One of the first products that they asked that we've been working on with Greenbush is this one-page document that's in your packet, front and back. As we were talking about gathering public input, asking the citizens to give thoughts about the location and site. We thought, well, they need a little context of what the building's going to look like, what it's going to do, how it will function. So we've been trying to take the last couple of years of development and distill that into a hopefully simple kind of one-page document. So that's what's there. Feel free to take a look at that. If you've got suggestions for that, we can gather those. But I'll turn the mic over to Monica to introduce the Greenbush team.
Thanks, Scott. Hi, I'm Monica Murnian. I know a lot of you in this room, and so pleased to be part of this really exciting opportunity that has come forth here in Sedgwick County. We all work for an organization called the Learning Tree Institute at Greenbush. Some of you may know Greenbush as an education service center. It's located in Crawford County. Greenbush is actually an unincorporated town in Crawford County, and that's very cleverly how we identify ourselves. The Learning Tree Institute at Greenbush has been around for about 40 years, and it is our foundation that runs alongside our school district. The foundation has done work for many, many years with several different agencies of the state of Kansas. We've done quite a bit of work for about 25 years with KDADS. So we're tickled to be part of this much bigger effort. We have a team of people that are very capable in different components of grants evaluation, public outreach, community input, surveying, report writing, all of those things. So we put our A team on this and are so tickled to be able to help in any way we can gather community input, good, bad, indifferent, from all different populations and all different formats. And in working with Scott and Melinda, as we needed to move very quickly, we started the process of location, what's our no-go on location. And in a minute, Dr. Lisa Pelkey is going to explain some early, easy steps that we have taken to start gathering input. And we also are going to ask for your help by the time this is over. We have one particular area that we need some help in getting some names and locations together. So our intent is to be supportive of this group in any way we can to facilitate so that you can do the important business the governor has asked you to do in this very complex yet much needed resource that you're bringing to Sedgwick County. So just real quickly, our whole team won't come every time we meet, but today we all piled in the car coming from different parts of the state. So I'll just quickly introduce you to everybody. Dawn Flores is here. She lives in Pittsburgh and has quite a bit of work experience here in Sedgwick County. Jen DeLee's in the back row. She lives in the metropolis of Girard, if you're not familiar. And she is our logistics do everything. We have Dr. Ryan Vaughn, who's coming from south of Topeka. His area of expertise is just about everything that has to do with finding out what communities need, a lot of work with kids, and brings a great background to this. And then today, I'm going to turn it over here to Dr. Lisa Pelkey, who comes from the Kansas City area. And she is heading up our surveying efforts. So we thank you for letting us be part of this. We look forward to working with you over the next however many months it ends up being, several. And we're here to support your efforts in any way possible. But Lisa Pelkey is going to visit with you about some early out of the gate efforts we've made to start gathering input from Sedgwick County residents regarding the location of the facility. So Lisa, take it away.
In my future life, I was a teacher, so I would be out here with you guys. Okay. So my name is Lisa Pelkey. I have a background in education as well as research from the University of Kansas. I've been researching now about 5 years on community health as well as some education literacy topics. So today I'm here to tell you about the survey that we have deployed. It is activated. It's currently activated by email only. Miss Mernan will be giving you postcards. We're also doing a mailer to all of the surrounding zip codes that are not in Wichita of people who may not have access to internet subscription. So we currently have the survey in English and Spanish for anybody who receives it. We also have the survey available, ready to go in 5 other languages per the that were recommended by the refugee center here. And those languages are Swahili, Arabic, Burmese. Thank you, Jen Lee. What are the other 2? Taiwanese,
Float out of my head.
French and French. So those 5 languages are also available. The survey is also in low vision, so for people to access if they have low vision needs, as well as it is at the 8th grade reading level for the general public, which is what our newspaper is written in. So it's recommended surveys be disseminated in the 8th grade level. So preliminarily, we have the email one out. I looked at it this morning. It's been out about 3 days. So we're showing that the general public at this point are marking would not like it next to a early childhood education center or an elementary school. I have noted those 2 things are at the top of my list. Again, very, very early. So I have the survey actually in 2 places. So in the second place, I'm going to move those 2 items to the bottom because they're currently at the top to see if that makes a difference. So know that I'm watching the survey very closely to make sure that what I give you is actually going to be representative of the population. So we're looking for a minimum of 400 for this size of population. I think we'll get way over. So what I present to you or what Greenbush presents to you should be representative of what we would see if the whole population was surveyed. So any questions about the survey so far? So far we are only at about 30 because we were doing a pilot.
So she calls it a soft launch over the weekend. We are focusing in on 3 strategies. The first was purchasing email addresses in the area. We soft launched with a few over the weekend just to make sure the survey worked. And then when's your launch planned?
So the next one where we will email the postcards, where we will mail the postcards will be today or tomorrow. Jen has those ready to go. So we're just waiting to
get those
out.
And on the postcard is the QR code as well as a written out link. So we've tried to make it so that it's easily accessible. The third bigger effort that we need to make is where it comes into needing some help from you. We feel like through the opportunity to be in some larger businesses and industry and workrooms with QR codes on tables and such, we can gather quite a few folks there. So, but we need to be able to get into those facilities. So any way that you can help us say to create an introduction saying, here's these QR codes, could you put them up in your break room or wherever, that would be very helpful. The target population of folks that are working in Sedgwick County is important to us. The postcards are specifically chosen the addresses based on what we believe to be low broadband areas. And we asked that through the Department of Commerce. So we're trying to do very targeted in different areas so that statistically the representation is appropriate.
Yeah, targeted yet random. So it's still random, but it's targeted.
And then as we move forward in the process, focus groups, any kind of community groups that you feel is appropriate for us, we will present. The one pager that Scott provided, as well as a quick 1-minute video, allows us to not be skewing the intake in any way. Everybody sees the same bit of information. It's not up for our interpretation. And so now that we have all those things, we're ready to go. Do you have any questions for us?
When do you think you'll be done with that and we'll see the results?
I would say probably the end of November. We're going to keep it open until the end of November. So the email probably in about 10 days, but our postcards and then through the businesses will go through the end of November. Make sure we hit all of our targets.
And we have information ready that if you want to have it electronically so that you can share it out, that's great too.
So I was wondering, when you talk about population, is it 500,000? What is the population you're looking at?
Our population is about 600,000.
And that's within this entire Wichita area,
That is
Southeast.
within Sedgwick County.
Sedgwick County?
Yeah, I used the 2020 census.
Okay, thank you.
We'll be here all the meeting, rest of the meeting and afterwards if we can help in any way. Thanks for the opportunity to be part of this important work.
Commissioner Lopez had a great question. So like we talked about last time, we're kind of on a quick deadline to have a report prepared to submit back to the governor and the legislature for this legislative session. So our thought was get this effort underway as quickly as we could, spend as much time collecting that data as we could, but then still get it compiled by the time we meet again in December. So we can use that to inform what we put in our report. And that isn't a whole lot of time, but again, it can just be as simple as we asked in this area 400 people, and the survey is a list of places where you think the proposed hospital shouldn't be located next to. And I think that's a pretty easy distribution to show what people would say is that kind of initial thought of where it should go, shouldn't go. And then so that can go into our report, and that may be, the bulk of what we say is we ask people, this is the first level of response that we got, update on other progress from the county and the state. And that's our first report, but trying to get the timeline aligned so we can get that report done for January. Other questions? I'm sorry, Representative Hobson, would you mind introducing yourself just so that you were virtual last time, so we're glad you're here in person today and we got around the table, but if you wouldn't mind.
Well, thank you. My name is State Representative KCO Hobson. I'm a representative here in the Sedgwick County area. I serve in Topeka. Glad to be with everyone here with respect to this mission on the advisory panel. So I look forward to working with everyone. Thank you very much.
Any other questions about state updates since the last time that we met? Okay. Anya, would you mind giving us an update from Sedgwick County on where we are on the project? And there's some materials at your place from Tanya's report.
Okay, good afternoon, panel. My name is Tanya Cole, Assistant County Manager. As Scott referenced, there should be a packet at your area. It is titled Tentative Timelines Mental Health Hospital. And so I'll be referring to that packet. So the first bit of information, we've got a couple of updates that I'd like to give you an update on. The first is our RFP for A&E, which is Architectural and Engineering for the Mental Health Hospital. Our hope is to get this out to bid today with a timeline of receiving returns on that A&E RFP by November 21st. Then we will review those proposals from November 22nd through December 12th, and we will have a team with Sedgwick County and KDADS, and that team will look very similar to the team that we had with the original A&E firm, GLMV, as well as KDADS, Sedgwick County and KDADS. So our hope then is to bring an award to our internal process, that is Sedgwick County Bid Board, by December 14th, and then approval before the commission on December 20th. And I have included, because it was asked at our last meeting, what the minimum qualifications would look like for the A&E firm. So I included that proposal in your packet. And if you want to refer to page 7, you'll see that I think there are about 28 items there included for the minimum qualifications. I know that at the last meeting, you said that you didn't want to be too involved in choosing the architectural and engineering firm, but I did want to include that because that was a request, and I promised that I would come back with a template of what our proposal would look like. So I'm providing that to you. So any questions on that before I move on to, I think, what's going to be the bigger discussion, and that's the land and existing building. Okay, so let me move on to the next handout, and that is this piece right here. This is the mental health hospital. This is the proposal that went out through our on-call real estate broker, Reese Nichols. So this went out, what I would say for proposal, October 25th, that it went out through our on-call real estate broker, Tim and Ryan Kerr. They are a son and dad team. Reese Nichols, they are one of our on-call real estate brokers. So that is, that's going to be out for a little over 5 weeks. We're taking those proposal until November 30th. Our timeline on that then is to get those proposals back December 1, and then through December 20th, that's about 3 weeks. What we'd like to do is what we're calling a phase 1, and that's to shortlist those properties, and that would again be with a team consisting of Sedgwick County and KDADS. And so I've tentatively put a timeline together of December 1 through December 7th of shortlisting those properties. What I'm then suggesting is a phase 2 timeline, and that would be with this group. And I don't know if this is the whole group or a subcommittee or a subpanel, as well as receiving public input. And I don't know what that public input looks like. I don't know if that's what we're receiving from surveys through Greenbush, or if we're looking at, a town hall type meeting. But I do think that we need to understand what that public input looks like. And so I've put a timeline together of 12/8 through 12/14 for that. Then I'm suggesting that we take recommendations and approval to the commission through that 12/15, 12/20 time period. And then we'll need some time to put together a purchase, a signed contract, a due diligence, and a closing period. That's approximately 12/20 through January 31st. Let me just explain that so far this proposal has gone out to, I think the list was over 2,000 real estate brokers. We sent this out to developers. We're looking at a second list to send it out to architects and contractors. We also have this on our website, and we're going to work with purchasing to make sure that it can be seen on our purchasing website, where we do have a lot of vendors that will go to our purchasing website for anything that we have out as far as requests for proposals, requests for bids. We want to make sure that we get it on our website there as well. We are working with our purchasing department to put out an addendum to make sure that those that have received this proposal also get a link to our website that talks about our purchasing FAQs and also receiving the federal grant terms and conditions. And then also we're working on evaluation criteria that basically they understand how the land and the building will be scored through the phase 1 and the phase 2 of this process. So I'm happy to answer any questions, but as you can see, let me just walk through the land, the land option 1 proposal. So it states that the land should be within the limits of Sedgwick County, utilities in close proximity. Land is to be close to highway access. Land should be 7 to 11 acres and must be or able to be changed to appropriate zoning. And again, that the acres that you see there, again, came out of programming, which I discussed at the last meeting. And then for option 2, the building, again, building should be within the limits of Sedgwick County. Building should be move-in ready or be able to be remodeled. Building is to be, again, close to highway access. Should be 75,000 to 112,000 square feet. There's a little plus sign there. That's simply because we couldn't really stop a building at being 112 square feet. So we know that it's possible for that building to be a little bit larger. That's what that plus sign indicates there. And must be or able to be changed to appropriate zoning. And so that's it for my updates, and I'm happy to answer any questions on that. But I think we've had some fairly decent progress since the last time that we've met on both A&E, getting that proposal out, as well as our land and building proposal. Yes, sir.
So does the 7 to 11 acres also apply to option 2 with the building?
Yeah, I mean, the building would, of course, hopefully come with parking
Right.
on that, but yes.
Okay.
Yes, sir.
So on this one here, on option 1, that's just building a new building.
Correct.
And how
Yes.
many square feet was that? Is the 50-bed facility?
Give me just one second. I can probably give you a number off the top of my head, but I want to be precise. So what we were looking there for the building was 76,231 square feet. That gave us 50 beds. And then if we wanted to expand to 100 at some point, that was 111,424 square feet.
Very good. In your RFP, are you going to list both of them? I think there might be some potential savings to build a 50-bed and 100 at the same time in that RFP because they're on site. I have at the last meeting, I've made my self clear. I still think that a 50-bed facility is going to be full day one. And I'm just very concerned about that. And if that happens, we're going to be another 2 years out before we get another building built. It seems to me like if you had the RFP where you could include the second phase of it, you could at least get an idea of how much it was going to cost during that process. Building costs are never going to go down. I mean, we could save, millions of dollars by doing it all at once and being done with it as a 100-bed facility. But I'm just stuck on that. And I don't want egg on my face when we go, it's full day one. What were you guys thinking? I just see the need, and we'll talk about a little bit more when we talk about Larned.
I think through our process, and when we hire the A&E firm, as we go through the process of whether or not we're building new or remodeling, we will ask the architect to specifically price out, okay, if we are building new and we're building a 50-bed model, can you help us understand what it's going to cost to build to 100, both in remodeling and in new? So I think we'll have that cost figure, but I think what we're building as of right now, understanding that we have 40 million, we are building 50 beds.
Okay. I'll be able to say I told you so.
One observation more than anything is, given this very tight timeline, and I get the need for it, I think before we leave today, we need some direction for these folks at make sure I say it correctly, at Learning Tree Institute. If their survey, the idea is we're going to come back by very end of March or end of November, rather, right before December, with probably a spot or two identified as the top 2 or 3 or whatever it's going to be. We'll have had hopefully 4, maybe 500 survey responses from all over the city. I've watched other things take place even very recently in the city of Wichita, with their selection of a temporary homeless shelter in the city. And there's already some response about that, and it having happened too fast. Well, they had to have it happen fast because that was the time crunch they were under. All I'm getting at is, if we're going to identify 1 or 2 or 3 spots, and then a very short turnaround, I mean, in less than a month, make that recommendation to the BOCC, the opportunity for a public hearing from the people who live in near those 3 spots is not something we're going to be able to put together at the next hearing in December. So I think before we leave today, we either make a decision that we're going to just live with the survey and that's it. Or if we're going to have a public setting, we need to figure out when and where to give the county time to get that set up. Otherwise, there's no way to pull that together. I've done these before and these are not something you pull together over a weekend. So just again, more of an observation, kind of a call to the question. What do we want to do? And give the folks in the county time enough to respond to what we want to do.
And Mark, I couldn't agree with you more. And at the last meeting, I said, we need to get it right. I don't care about this timeline, quite frankly, and the time that it's supposed to go to the legislature and all that kind of stuff. If it takes another couple of months to get it right and do our due diligence and know what we're doing, I don't see a problem with that. I can't even imagine anybody having a problem with that. But the last thing we want is people harping at us that we didn't do it right.
Well, I don't anticipate there being a group of people who are going to be excited to have a mental health facility in their neighborhood. But to give folks the adequate opportunity to be heard and make recommendations is part of the process. And I'm not saying we go into it with our ears shut, but there may be something that in those meetings that is brought to bear that something we hadn't thought of. And so, again, I'm just stating the point that it's something we can't not address today in this meeting before we leave.
And thank you for bringing that up. That's something that I wanted to say as well. The survey is great, but I do think that we need to have a public input process somewhere. And if we can set up a time and then I think once we have better ideas of where these are at, then we can pick a location. Maybe that might be more centralized to where those spaces are. But I do think that we need to at least plan to do something to get public input, because I don't want have an immense amount of pushback because of the space that we just pick and hope that it's going to be right. And then I do want to comment on the timeline. We will have to be under a pretty strict timeline just because of the money that we're getting in has to be accounted for by a certain date. And as we all know, so many people are trying to get so many construction projects done that we can't put ourselves at risk to not having that done, because then I don't know who would be liable then, but we would have to pay money back federally. And I don't think the Citrus County is going to cover that. I don't think the state wants to cover that either. And so I just want to make sure that we do this as quickly as possible, knowing that we have to do it correctly and we have to get it right.
So what is that time frame? For the 2026?
December 2026.
So yeah. So I think we'll put it on 2026.
December 2026, when the ARPA dollars need to be spent. There'd still be state money that's attached to the project as well.
Right, but that still is 2 years to spend that money.
Right.
Okay.
And I appreciate Commissioner Lopez mentioning that, because when in the design architect work, when they showed us their proposed timeline or a timeline based on what they observe and building other projects, it ran out almost exactly at that December 2026 deadline, with these same dates of having property identified before the end of the year and the design and construction document production process happening at the beginning of the year. So we can add time. And that's just an estimate. It is what it is, but that was the timeline that the architects gave us when we talked about this as a concept with 50 beds and potential for expansion.
Well, and from one more clarification, we can spend until the end of 26, but we have to have every dollar obligated by the end of 24. So there is, that piece of that as well. Yeah, thank you.
So the only other thing I'd add is I absolutely agree with the commissioner and the DA in reference to this community here is used to town hall meetings to be able to discuss major entities such as this. That has to be done. And utilizing Greenbush and their survey, that type of stuff is a great concept, but the folks here absolutely expect face-to-face. And I agree with Commissioner Lopez that a face-to-face on the original aspect. And then when the property locations come in, that's got to be a second meeting. The other thing that I'd ask is I also agree with Representative Carpenter. I mean, we already know the evaluation portion of the beds, we would fill them and still need one more bed today. And, those there was a lot of discussions on what those beds would look like. Let the mental health professionals kind of answer the questions on that. That's what was settled on 25. Yes, we would fill it in the beginning, but the hope is that they would work through a lot quicker and you wouldn't be filling those beds. However, I agree that we're probably going to fill those beds. So my question to Tanya is, obviously we have a finite amount of money to spend. But the third option of being able to build it to add on, is that an option with the money that we have allocated this project? Because I think that's a necessity, because I don't think there's any doubt in some folks' mind here that we need more than 50 beds, but that's the money that we have to spend.
So what we're doing on this is the way that this is programmed, or the way that we've put this out, is with the land 7 to 11 acres, that has the vision of being able to add on for those additional 50 beds later, as well as with the building that has the ability and the foresight to be able to add on later for those additional 50 beds. So again, as we're working with the architect, what we will do is we will ask them to build this for 50 beds, but we want them to give us the information on what it would cost to build 100 beds. And we will be open and transparent with this group and with any other group that wants to know, if you want to take this to 100 beds, here's what this will cost. And then it becomes, a decision point at that point, if you want to move to 100 beds from the get-go.
But the construction design in the beginning would allow for, at any point, that building to be expanded without a whole lot of cost building a brand new building.
Yep. If you remember, what we talked about was we are building this building for the administration, the maintenance, all of that to already have that infrastructure for the 100 beds. So all we're doing then at that point is we are just basically adding on the future 50 beds. Everything else, the infrastructure is already there for that 100 beds. All the administration, offices, the facilities infrastructure, everything else will be there for the 100 beds. Only thing that we'll need to add is just those additional beds.
Right. Thank you.
Yes.
Oh, hold on just for 1 second. So operationally, we have 15 million a year from KDADS. Is that correct? And so that plus the 25 million we've received is how we got to the 40. But if this isn't going to be ready to go until 26, is it possible that if we see that it only takes so much more to go to the 100 beds, can we use that 15 million for another year? So instead of having 40 million, we have 55 million. I mean, is that, I don't know what the reality of that is, but.
So those are dollars that are in our base, in the KDAD's base budget for operation of this facility. But we can reprogram it for construction with the recommendation from the governor and approval of the legislature. So I don't think that's a big lift. I think it's going to be more than $15 million though to add the 50 beds, given the scale. I mean, it's incremental, but I think it's still probably more than that. But that is something that's on the table that could be, as things go, that's a pretty easy request to make. And I think we'd get some good support from the legislature and the governor about
That'd be great. Thank you.
So there's $15 million there's $15 million in our budget this fiscal year that runs through next June.
Right.
And then there's another $15 million in our base budget that'll be for the fiscal year that follows that.
It is in the government budget.
It's in our request, and I don't have any reason to think it won't be in the governor's recommendation going forward. Two different things, but I don't have any reason to think it's not going to be there. But it's identified as for operation and construction of this facility. And the idea was we'd be built or in the building process by now or shortly, and we need some of that funding for operations for the staff up and do all the things that would to actually serve patients, but that's not likely to happen given what the time frame is like. So we probably need some explicit permission or authority to use that money for additional construction costs or to add 25 beds or whatever that might be. I don't know how far that would go, but.
Well, kind of where I'm thinking too is what, I can't remember that email now. You're talking how much we're gonna spend at Larned on overtime this year on contract labor, 40
$40 million.
40 million, $42 million. If we can take some of that off of the table for spending on that contract labor and put into this hospital, we'll be way better off. You know, that's a pretty big hit. And I think this hospital should take, correct?
Hopefully. I mean, I think we need every bed in the system that we have now, and plus these 50. It might make staffing easier. It's a complicated formula with lots of puts and takes, but should help with capacity and wait time for sure. If we
Yeah,
if we can staff this.
Exactly.
Representative Hobbs, I'm sorry.
Oops. Thank you. Just to follow up on what Sheriff Easter just said in regards to, of course, we have more needs for beds right now. I am in line with Representative Carpenter, and I think we need more than 50 beds. So my question is, I don't know if you answered it, the money that we have right now, I know you said it was for the administration and all of that. Is there money, will that, after that's built, will some money be left to actually add on per se in the future? I don't know if you answered that question. Is that already in that budget, or later on we have to request more money to build it?
Yeah. And I may defer to Scott on that. I mean, Scott, do you want to answer that? Because I think the money that we have now is basically for.
Because my concern is, I agree with, let's get everything right, do all at once versus, later on, and maybe building material goes up and all of that. So that's my concern. So, and I have a follow-up question. So second is in regards to land option number 1, wherever the site is, are any testing going to be done on the land to make sure it's not contaminated per se and all of that before purchasing?
A series of testing on the land.
Okay.
Absolutely.
Okay. So I think that was my question. Sorry.
So with the budget that we have for the building, the $40 million is the number that Sedgwick County requested in their iterations of Spark requests. We validated that as well to say that's what we think we would need to build 50 beds. And what we've designed that's on the screen is 2 living units that are at the bottom there in blue. And then everything above that are the support areas for the hospital. When we were working on the programmatic design, we said build that or design those spaces so that it would accommodate 100 patients. So what we'd add at 100 is 2 more living units like that. And they're shown proposed on there out on the wings, but we wouldn't need more. In the power plant would be sized to support 100 patient rooms or for 100 patients. There'd be enough recreation space, storage space, intake space, assuming there'd be more volume as well. So the core of it is within that $40 million appropriation. What we've talked about is the project budget. When we then have to go out and build those 2 extra living units, there isn't funding in the budget that we have. We think, based on, we don't know what the construction costs will be, but that's what we're going to try to build first.
2 things.
Those are ready and then.
Thank you. I think before we start discussing moving funds from Larned, it's very important to be cautious when we do that, because the mental health needs are so extensive that I don't want us to assume that we're somehow alleviating some of the pressure off of them. Theirs might still be the same, if not more, because there are so many individuals that need services right now. So I hope we have that discussion before we think about ways to move funds away, because I think their challenges across the state are huge right now, and wait lists are everywhere, and people are in crisis right now and they don't have a place to go. So I think that's something we need to have a discussion about at a future date.
Just 2 things. Tanya, there's nothing in this RFP that doesn't get us to where Representative Carpenter wants to go on looking at cost and analysis of an expansion to 100 bed.
Correct.
I mean, because I concur with everything that's been said there. We ought to be looking more than 50. Secondly, on the town hall, I agree with Sheriff. and we're running into holidays here and we're on a really tight time crunch. I would suggest we look at something between right after Thanksgiving, but before Christmas, first or second week of December. And we can host that here at a county facility, a zoo or EP or here, and hear from the public in conjunction with the survey. I think that's a great idea and we ought to move forward with that.
Well, Tom, I'm looking at the short list that Tanya gave us. So 12-1 to 12-20 is the short list phase one. Within that short list phase one, 12-1 to 12-7 is when she's really wanting to zero in, if I'm getting my dates right from what you said. And then 12-8 to 12-14 is the assessment time with recommendation of the BOCC by 12-15, which means we've got the 12th and the 13th. Those are our 2 dates to choose from. If you do it the 14th, it'll be the night before. We'll have a public hearing the night before the recommendation of BOCC. I don't think that's sufficient. So I'd recommend that Tuesday, the 12th, Wednesday, the 13th are
Our only BOCC meeting will be 12-20. We do have a 12-13 and a 12-20, but the BOCC here in Tanya's would be 12-20 that we would.
Correct, that's right.
So back to your comment, Mark, it'd be the week before that, correct?
Yeah, and if we do have the 20th, then that would at least give us the date. We'd have one more date in there, the 18th, to choose from. I forgot to say that I believe our next hearing is the 11th.
Yes.
So that would give us 12th, 13th, 14th, or 18th. No one's going to show up on a Friday night during basketball season. So, let's be realistic here. But my point is that 4 days is what we've got to choose from. So I wanted to make sure we highlighted that.
Tom, can I go back to your first question? Because I don't know that I answered you correctly. You asked me, is there anything in option 1, option 2 on land and building that gets us to the 100-bed option? Is that correct?
Well, I want to make sure that the RFP is flexible enough that when we're talking to these vendors, that we can talk in terms of 50 to 100. So we can answer Representative Carpenter's question of how much would it cost to go do it the right way to start with. I like how this is laid out. I think it gives us flexibility to move toward that, but we'll be able to answer his questions at the end of this process, right?
Yes. So let me just answer this. The land 7 to 11 acres, that gets us to 50 to 100 beds. So it has the flexibility if at some point, if we're building 50 beds on the land and at some point later, 5 years down the road, 3 years down the road, we want to add on those additional 50 pods on that land. We can do that. The flexibility is there because we've bought that land in anticipation of building to 100 beds. Same with the building. 75,000 is what we needed for 50 beds. The 112 gets us to the 100 beds. So if at some point there's funding or 2 or 3 years down the road, we decide we want the 100 beds, that flexibility is there in the size of the building. Right now, what we're doing is we're building the 50 beds because I think we only have the funding for the 50 beds.
Yeah, and I understand that. I'm saying, I guess if it's going to be another $30 million to do the 50 in 2 or 3 years, but while they were building this building and it was going to be 15 million, it makes no sense not to go ahead and do that.
And that's why I was saying, as we're going through this process, we'll be working with the architect to say, okay, understand that we want 50. What's it going to cost to build 50 more? Is that 15 million? Is that 20 million? And then to me, that's a conversation that we have to have at that point to say, okay, we're at a stopping point here. We've got 40 million in for 50 beds. It's another 20 million to do another 50 beds. What do we want to do? Do we want to build 100 or do we want to stay at 50?
Exactly. And so the way I operate is I never treat the people's money any different than my own. So if I knew it was going to cost another $25 million because they're not on site and building it all at the same time, we would build it at one time.
The only problem is at this point, I don't know what we're going to get for land or building, but we've just put the parameters in there.
I know.
Yeah.
We just need to know
Yeah.
that. Thank you.
Yeah.
One concern I have, and maybe you can clarify. I mean, I think when we're talking about building new, it's pretty easy to do an apples to apples comparison. My concern is on a remodel, having the time to appropriately cost something like that? And what are we asking as far as these proposals? Are they going, do they have the programmatic pieces where if it is an existing building, they're going to have that costed out, or they're going to rely on us or our architect and engineer that we end up selecting? I'm concerned about that timeline of being able to actually have an apples to apples comparison by the time we need to make a recommendation.
I think that's a valid, I think that's a valid concern. I think that we'll have to look at that ourselves. I think we'll have to understand the condition of the building and do that evaluation.
Good discussion. Tanya, I had one question. So given the we're coalescing around needing to have a public meeting sometime in the first part of December, what the timeline looks like for that RFP, what can we actually share with the public? If we've got, let's say we get 10 proposals in, some combination of greenfield and buildings that are available, what you'd proposed was kind of there be a short list developed. The county and KDAD's rule some out that are clearly bad fits and leave 2, 3, however many. Do we have to, can we share those 3 that meet the short list cut with the public before the other 7 have been ruled out and told you're not a contender? Or would we have to show all 10 of the proposals that I'm just trying to figure out how to scale the presentation of, for the public,
Sure.
I completely agree. We got to gather the public's face-to-face input on a site, but I don't know whether it's every proposal that we get or the ones that we think are the best fit.
And we've done that with buildings that we looked at, but would you reserve me the right to get back with you so I can check with our purchasing department and as well as our ARPA consultants, just to make sure that I don't say anything incorrectly? Oh, Lindsay, you can answer. Okay. Lindsay's going to answer for me.
Hello, everyone. I'm Lindsay Peruso. I'm the CFO for the county. And with regard to the ARPA requirements, we would probably have some concerns about sharing of that information out publicly for any of those specific sites. It doesn't mean that you couldn't talk in generalities about types of locations or types of projects just to get some general feedback, but we wouldn't want to actually we wouldn't want to be in a position to allow some kind of interference in the process of it going to the county's bid board and then going to the county commission. And so that's why we would have to kind of be careful about what specifics have been given to us, price points and all of those things, because that would interfere under the federal rules.
So if we had, in the bid responses, we'd have price points, or at least what the bidders were suggesting the prices would be. We don't need to share that. The public might be interested, but that's
right.
Less relevant as things go. But location, we can't mask. So if it's a greenfield, we could put up a map and say, well, we've had 10 proposals. Here's where they are on the map. Can we show that much of this one's at an intersection of this and that's going to kind of give away what the building is if you point out the intersection, I think.
So probably, and we would want to refine this when we have some better idea of what things look like. But in my mind, that would be, we would have new construction in the northeast section of Wichita, or we would have a building that could be remodeled in unincorporated Western Sedgwick County. Some general parameters to talk about 50 to 100 beds, how much parking, maybe if rezoning would be required, just to give folks a little bit better idea of whether we're going into a residential neighborhood or something that's maybe commercial. I think we could get away with that, but I think you're right. Once you start giving away intersections or specific plots of land, I think that's where we lose that protection under ARPA.
Okay.
Last
Anybody
question
from
is,
the county who's done this have experience with that level of, you mask the details enough to be
compliant
and still feel like you're able to gather good input from the public about a location?
I haven't, but all I was going to say is this sounds like, so we don't, I mean, we could talk about this for another hour. I wonder if maybe a subcommittee or this needs to be assigned to somebody to get, and we can keep talking. I don't want to stop the conversation, but I think that the answer is a plan is going to have to put together and probably more than we're in a position to do in the next hour. So just an observation again.
No, thanks for that. But maybe we'll, Senator, go ahead.
Sorry about that. I think one of the things we can highlight is if we have enough survey input from the online and mail-ins and everything where people don't want it. And maybe that way, that's something we can highlight. Here are some areas that it's not at, and a subcommittee worked on more specifics of it.
I was going to kind of make that point as well, that with the surveys and everything that Greenbush is doing here fairly soon, we can take that information and draft kind of how this would look like, and for the public input to give that same input, but here's what we're already seeing. I think I agree with Mark. If we as an entity want to put together or assign somebody as a subgroup, working with the county, who we do town hall meetings quite a bit, I think that would be the easier path than the group of us in here trying to figure this out. And then incorporate some of the ideas that have been thrown into here, and then either by email, because we won't meet again before the town hall, but put out what that plan is. And so I would suggest that we appoint somebody to be in charge of the subcommittee to get this part of it done.
I'm going to let that just kind of sit in the room and have you think about it a little bit, and maybe hear from the superintendents at Larned and Osawatomie on what they do, not to distract you so you're not paying attention, but just to kind of let that sit in the room. Because I think that the two things that I heard were kind of narrow, well, the need for a public session sometime the first week in December, and then we need to figure out what we can actually share based on the proposals that we get that we haven't seen yet. So there's some pretty significant unknowns in that scenario, but a couple things there seem to be consensus around. So we will come back to that. Thanks, Tanya, for the presentation and the help from the county folks. With that, we'll move to the next item on the agenda to hear from the current state of state psychiatric hospitals with our two superintendents, Dr. Lindsay Dinkle from Larned and Ashley Byram from Osawatomie State Hospital. These are two extremely talented people who I'm fortunate to get to work with most days, and they tolerate me a lot of the time. So I'm excited to have them share just a little bit of information about the current state hospitals and how they operate, and some capacity questions that came up from the last time. And again, think it's helpful context. So Lindsay, I've got the clicker, so I will move through the slides as you tell me to, but feel free to introduce yourself and go ahead.
Okay. Good afternoon, everyone. As Scott had mentioned, my name is Lindsay Dinkle. I've been out at Larned State Hospital. I think I'm starting my 5th year here. I was previously a therapist on our sexual predator treatment program, and then I ran away for a year and came back and joined the administrative team as the chief operations officer and the assistant superintendent. And then about, 2 months ago or so, took over as superintendent for the hospital as Miss Lisa Dittman had decided to retire. So I'm excited to meet and see you all. Several of you are familiar faces I've seen, so nice to see all of you again. I will hand it over to Ashley and let her introduce herself real quick before we jump into our PowerPoint presentation.
Okay, thank you, Lindsay. My name is Ashley Byram. I'm the superintendent at Osawatomie State Hospital. I've been here at the state hospital since 2005. I started as a social worker doing discharge planning. Since that time, I've had several different roles here at the hospital, including program management, director of social services, assistant superintendent, and for the past year, I've been the superintendent here at the state hospital.
So we're excited to kind of jump through and educate some of you guys on the current services that we do have going on across the state. So, all right, I can kind of see, Scott, I can see from your guys' screen the PowerPoint presentation. So I think I should be good to keep up.
Okay.
state mental health hospitals, as Ashley and I started kind of mentioning, we have Osawatomie, there we go, Osawatomie State Hospital, Adair Acute Care, which is also out by Osawatomie, and then clear out west, Larned State Hospital exists, and all serving individuals who are suffering from serious symptoms of mental illness. And so individuals that are coming to our hospitals have been considered a danger to themselves or to others. So they may be presenting suicidal, homicidal type symptomology. They may also be going through the psychosis, maybe fluctuating throughout challenges with bipolar disorder. We're talking pretty moderate to severe level of mental health impairing their standard functioning. And so those individuals are going to come into one of our hospitals, depending on where their home county is, and we will be able to provide them stability services that they would not be able to necessarily receive to the same capacity as what they might have received in the community. So we will provide that assistance with the intention to get them discharged to the next least the least restrictive environment. Hopefully for many of them, they have good support systems, so we can send them back to a home setting. But others, we might have other step downs that are a little bit more freedom bearing and using a little bit more of the community-based services to help them maintain in the community. And with our services, we also continue to monitor and maintain some slightly medical type issues while they're here, if those are also going on, but our predominant focus is going to be the psychiatric care. So if you want to jump to the next slide, Scott, it'll give you an idea of our bed space. I'll talk about the LSH side, and then I'll let Ashley jump into the Osawatomie side. For LSH, our psychiatric services program, which I'll expand on a little bit more here, but essentially those individuals that are going through that mental health crisis type situation, we do have 90 total beds budgeted for this particular program. Our average census from last year was around 73. We do currently cap our census for the PSP program at 74, and that is strictly associated with some of our staffing issues. Unfortunately, we, as you've discussed briefly, have a heavy dependence on agency staff to keep our units running, and unfortunately we just don't have the financial resources to have PSP functioning at its full capacity. And so we currently function at the 74 cap number right now. For state security program, SSP, which ties into the competency evaluations, restoration, a lot of those pieces that you guys have been talking about with the wait list. Our budget for beds is at 140. However, our average census from last year was at around 89. Again, this is another program that we have had to shut down units because of staffing issues. We do have the physical capacity to open up another unit of 30 and be able to provide additional services. However, we don't have the staffing, direct care staff, and then even clinical staff would require additional people to be able to manage that. So we're not functioning at the full capacity there either with that. And that cut, both those cuts came around the COVID time when we went ahead and had to make some space for just general COVID isolation units, but also to the staffing just annihilated us around that time there. And then the sexual predator treatment program, which I won't talk about as much, but it is something that does suck up the resources out at Larned State Hospital. We are budgeted for 274. Our average census is around 245 for that for that program. That's a very slow moving program, so we do not see movement go very rapidly with them. So that stays pretty stable as far as numbers. And then lastly, for LSH, we do have one of our reintegration facilities where our sexual predators who have gone on to a tier 3 or a transitional level of their programming are housed in kind of like a halfway house, so to speak. We're budgeted for 16 on that, and we currently are around, hang around 9 residents, give or take. And so that's what the bed space is what we're balancing for the Larned facility. And then just briefly jumping down to the summary of staffing, LSH has around 920.5 positions allocated to them in order to try to effectively run the hospital. But as noted, a very large chunk of them are funded or being managed through agency staff. Ashley, I'll let you jump on your side.
All right, so for Osawatomie State Hospital, we actually have two state psychiatric facilities on grounds. We have Osawatomie State Hospital, which we are budgeted for 116 beds. On an average census, we run about 102. For AAC, which is a day acute care unit, that is 60 beds. That is our CMS certified hospital. Our average census there is around 38. The reason that does tend to be low is all those rooms are double occupancy. So a lot of times when someone comes in and they're in an acute state, they do require a private room. Therefore, that does limit our bed capacity because it takes up a room that could be used for two individuals is only going to be used for one. But also the unit that the building that this is on is very small. And if you do start having 60 individuals in that unit, it does become very loud and is not very therapeutic. So we do tend to cap that at 52, but most of the time we're not at that level due to the single occupancy room that we do require. Also, we do have SPTP reintegration facility here as well called Myco House. That is not listed, but we are budgeted for 16 beds. Today we have 9 individuals on that program at this time. For our summary of staffing, again, as Lindsay mentioned, we are having to use a lot of agency nursing staff. We've also had to tap into other agency services for housekeeping, social work, and therapy services right now is what we're looking as well. But for OSH, our approved positions 377, and for AAC is 155.
I'll go into just a little bit more detail about the 3 programs I mentioned for Learned. As you'll see up here, we're acronym friendly with PSP, SSP, and SPTP. I'm going to jump to the next slide. Okay, so diving into a little bit more detail of the PSP program. This program can serve both voluntary admits as well as civilly committed. However, just because of our staffing needs and the cap that we put on the program, we haven't been accepting voluntary admissions for quite some time here. So all have been through the courts. Individuals who may be going through kind of a mental health crisis, having some of those psychosis experiences, homicidal, suicidal struggles, they will be assessed by a qualified mental health professional. And if they are deemed someone that cannot be provided the care in the community service and need a little bit more structured and constant observation and a more secure setting, they will then be screened into OSH or LSH depending on their catchment area. We tend to have kind of the central and everything west out into the boondocks, and then Ashley's crew has everyone more out east. And so once they've been screened, they'll come to us, and of course we have the criminal justice system, or not the criminal justice, we have the justice system involved as far as just monitoring their civil commitment orders and things of that nature. This gives you just a snapshot of the numbers that we had last year for admissions and discharges. 462 patients admitted with 533 discharged. I just pulled the numbers last week, and right now for January 1 to October 31st of this year, we're sitting at about 496 admissions for the psychiatric services program. And again, that's with having the cap of 74 enforced all year round here. We have found with having to go on kind of a cap, we have had time periods we've had to go on to a wait list. Our wait list has been for the most part fairly identical this year as it was last year, although we've found some relief with some people getting admitted through SIA agreements and other resources that have become available. But we do find that some individuals will have to temporarily wait to be brought in. As of right now, for instance, today, we're currently sitting at a census of 72. We have 2 beds available. We have no planned discharges or anything, but no one waiting to come in. So it tends to fluctuate. We are kind of anticipating with getting into the fall time here, we tend to see our admissions and things jump up around the holidays, as it can be a really tough time for certain individuals. So we're kind of prepping for that to sneak up on us. And then jumping to the next slide is going to give you a nice little snapshot of what we're getting as far as counties and admissions within our catchment area out at LSH. Again, this is looking at January 1 to October 31st of this year. We have the counties that have at least 11 or more admissions are listed to the right in the table. And you can see where some of our a little bit higher counties are. Saline, Reno have a pretty nice chunk. Ellis County are kind of our top three. And then you'll see here about a third of our admissions from PSP come from other more smaller counties with 10 admissions or less. But that gives you kind of an idea of some of our kind of hot areas where we tend to get more admissions for kind of that crisis stabilization service there in the PSP program. So jumping over to the state security program, this is the big one where we're trying to work on knocking down some of that wait list. The SSP program, known as the State Security Hospital in the statutes, is budgeted for a total of 140 beds with a current capacity of 100 adult male and female patients that are charged with felony crimes. Within this program is where we are following the criminal procedures of doing competency evaluations, company restorations, treatment in lieu of confinement, lack of mental state, and so forth. With SSP, there's no catchment. Lawrence State Hospital is the only place that takes in the individuals to help assist with some of these criminal proceedings. And so when I had last checked, we're getting closer to hitting almost the 200 mark on our wait list. When I looked last week at the end, we're sitting at about 30 individuals on the wait list that are specifically from Sedgwick County. So it continues to grow. And unfortunately, there's been months where we have not been able to get ahead or even necessarily max out with the number of people that are brought in and discharged in a month in comparison to people that are ordered for some type of competency service and are added to the wait list. Another piece I wanted to add for the state security program is that it does have what we consider a security behavior unit. This one is a 20-bed unit on Isaac Ray, one of our most secure buildings. And this is where male patients are administratively transferred from either OSH or our PSP program because of heightened aggression and just concerns with their or a need for a little bit more restriction and secure support to be able to stabilize them while they may be receiving some higher level of care. And so that piece is also feeds into the SSP program. And it tends to go in flows of where it maxes out and hits its 20 mark and then has moments where it might drop down and we might get down to 15 or 16, but we can find some challenges there where sometimes our patients will get stuck with stabilization, but we do have that as well. The next slide is going to give you a breakdown of what it looks like for admissions for SSP in regards to counties. And again, same coverage period, January 1 to October 31st. You can see over here, we've got Sedgwick counties. We've had 25 admissions so far this year coming from your area. Shawnee County, Wyandotte both have pretty large chunks of admissions. Johnson County, Douglas, also within the double digits. Our other section is going to include any counties where we've had 3 or less admissions for the month. And again, we're looking at about a fourth of our admissions are coming from those more smaller areas, and then gives you a nice breakdown of what we're looking at for these others. Going into the next slide, we'll just talk briefly about our SSP mobile competency service. This is a step that we have taken to try to help alleviate more demand off of Lawrence State Hospital and trying to serve some individuals within the community that are needing some competency evaluations or restoration. So with this, when we have individuals that meet our criteria for mobile competency, meaning they are oftentimes medication compliant, they're not showing aggression, they have agreement or willingness to engage in services, then we assess them in efforts to come to them in the county jails and be able to provide those competency evaluations or restorations. So that is something that we very frequently review. In fact, just last week, we went through our entire wait list again, and we're double checking and reassessing individuals to see if they were potentially had potential changes while in the jails and might meet the criteria for mobile competency, so that we could try to provide the service to them and try to get them off the list. Something that has recently changed, of course, with change in law and statute, and that is allowing us to be able to, with the correct court orders, pursue mobile competency for individuals. And if they, within the 10 days, we feel they are not going to be restorable or see any issues with it, we are able to still preserve them on the list and not necessarily allow them to jump in front of everyone prior to the statute change. If we pursued someone for mobile competency and we did find that they were not going to be able to be restored or carry out our responsibilities within the community, we then had an obligation to bring them into Lawrence State Hospital because of our timeline. And that then in return results in us essentially jumping someone clear in front of 180 some other people. And so we're still trying to increase the capacity of what mobile competency can do based on that recent statute change. So you'll see here on the slide, we're collaborating with several other counties across the state in order to try to assess the individuals on the list. There's some specific counties in particular that we have worked directly with to try to get mobile competency going a little bit more, such as Douglas, Geary, Leavenworth, Sedgwick, Shawnee, etc. We've also hired specifically a psychologist that is actively going and traveling throughout the week to these different jail settings to provide these services here. So it does provide some relief to us, but not always a lot, just because a lot of the individuals are quite sick, struggle with medication compliance and things of that nature, which does not allow us to be able to do mobile competency with them. So. And then just to give you a quick screenshot of kind of what our mobile competency numbers have looked like. On the left, you'll see just a breakdown of last year's number of mobile competency evaluations we completed between either an evaluation, a restoration, or just a standard sexual predator evaluation, which is kind of not the expertise focus of it, but is something that we also do. And to the right is where you're going to find more updated information tying into this year and just how many mobile competency evaluations we've been able to complete this year so far. So we start off pretty solid at the beginning of the year, kind of seen a drop, and then we kind of go and flow with people, but that's something that we continue to assess and reassess. Something else I do want to add just before I hand over to Ashley for Osawatomie is with the closing of one of our units for SSP, we have had to specifically create 2 units, one where it's considered people that are more vulnerable or high risk of being essentially preyed upon or people taking advantage of them, versus a unit where we have more higher aggression, higher risk individuals. We're finding that we are starting to, with all of the individuals on our wait list, we're starting to run out of individuals that would be appropriate to go to our more vulnerable unit. So that vulnerable unit at this point here can take a capacity of 30 patients, but is not currently full because essentially a lot of the individuals that are left on our wait list are individuals considered higher risk and people that would not be appropriate to put in that vulnerable list. So we're kind of finding another catch to where we're struggling to keep the things flowing because we don't have an appropriate unit to place the people on our list on when they get to campus here. So that is a brief summary of 2 of the primary programs pertinent to you guys for Out It Wanted. So Ashley, I'll let you brag on Osh.
All right, thank you, Lindsay. As I mentioned earlier, at Osawatomie State Hospital, we have 2 different psychiatric hospitals and grounds, Osawatomie State Hospital and Adair Acute Care. Actually, last weekend, we just celebrated our 157th anniversary for serving adults with mental illness. We serve 45 different counties in Kansas. We also provide services to individuals who are passing through the state of Kansas and end up being screened by the mental health center. 47% of our patients served by OSH and 87% of our patients served by AAC also present with co-occurring substance use disorder as well. Again, all of our patients that are screened by the mental health centers are referred to us either by the court, or we are also taking voluntary patients if we are below 85% capacity. Most of the time, our Adair acute care is below our 85% capacity, so they are able to accept voluntary patients, while our OSH side is pretty much always over the 85% capacity, so they are only able to take involuntary admissions at this time. As I mentioned earlier, OSH is licensed by KHNE for 116 beds. We provide acute intensive inpatient psychiatric treatment. We have 2 units, one that's 30 beds and one that is 26 bed for individuals for care and treatment. In the past year, we did add an additional criminal court unit. So we have 2 technically forensic units for individuals that are coming in for competency evaluations, or individuals that are on what we call a dual commit. A lot of time individuals who have been at LSH on the state security program, who are still not competent, need some continued education, they will be able to come to us for the least restrictive environment if they're based on this part of the state. So we will accept those individuals as well. So we have 60 beds that we focus on our competency cases. Then we have our Adair acute care, which is our 60 CMS certified acute psychiatric unit. We also do accept social detox, which we started over a year ago. That was suspended for several years due to a moratorium that was put in place in 2015. That was lifted. So we do have 3 social detox beds available as well. As I mentioned earlier, both of our hospitals have semi-private rooms, which does cause an issue at times due to patients requiring that private room. So when someone does require that private room, that does take another bed offline. So this is our current admissions by county. And again, this is for Osawatomie State Hospital. As you can see on this, that our primary counties over there are Douglas County, Johnson County, and Sedgwick County. And that goes from January to October of this year. And for AAC, which is where we have most of our admissions, those counties are Johnson County, Wyandotte, and then Sedgwick. In the past year, we did, as I mentioned, we've been collaborating with Larner State Hospital on a regular basis to see about decreasing that competency wait list, which continues to grow immensely. So we have been working with them on seeing if there's individuals that might have been ordered out to Larner State Hospital who we could provide the competency evaluation and treatment here at OSH. So we have been able to work with the district attorney's office and the courts to see about getting those orders changed so that person can come to Osawatomie State Hospital to someone that could be served here at this least restrictive environment versus having to go out to LSH. We have been able to take several individuals off that list. But at that time, also, we decided that it was best for us to change another 30-bed unit to focus primarily on competency. So at this point, we do have 2 beds or 2 units, excuse me, for total 60 beds for competency evaluations.
I think that's the end of your slides. One thing we didn't put in here, but if you could both speak to it, is your average length of stay for each unit, maybe Ashley for the OSH side and then the acute side. What are the average lengths of stay?
Yeah, so for the acute side, Adair acute care, our average length of stay is 11 days. For Osawatomie side, that tends to be around 90 days. That length is due to the individuals coming for competency evaluations.
And Lynn?
Yeah. Ours are very similar. We tend to see on the PSP side around 7 to 11 days is typically our kind of key numbers there. Our SSP sometimes vary a little bit higher. We can sometimes get a little bit closer to doubling those 90 days just because of the intensity of the mental health challenges that our patients are going through that come to us. So usually hit between that 90 spot, or if we have to extend it another 90 days to additionally work towards that competency restoration piece, then we might get a little bit closer to the 180.
Thanks for those that presentation. It's a lot of information about the work that they do. Any questions that we can direct to that? Senator Ray.
So thank you. I have 3 questions. Thank you for the information. I hope to come down and take a tour of your hospitals. I meant to come on Saturday, but I unfortunately had other engagement at that time. So like I said, I have 3 questions. One is out of state. How does that occur? Are those people that are visiting and happen to have had a mental health crisis, or are they brought in primarily because they have a mental health crisis?
Well, what we see a lot of times is a little bit of both. You have those individuals that are coming in for a holiday, such, we're getting ready to come on to the, Thanksgiving and Christmas holidays. A lot of times someone went and saw family, they're not doing well, they start decompensating, and the family reaches out for assistance. But also what we see, we have I-70, I-35 that come straight through the state, and a lot of individuals are getting pulled over or disrupt during a general traffic stop, and then they get screened through that way. And then we have to work on trying to get that person back to their home state.
Okay, thank you. The next question is, so I'm from Riley County, and we have Pawnee Mental Health there, and she covers, their organization covers close to 11 counties, I believe. And I saw several of the numbers here, but when I go to their meetings, they're also talking about people that are on a wait list, either to go to Larned or to, specifically to Osawatomie, are usually waiting in the ER room, and some are in jail. Is that what it tends to be? Some have been in the ER room for 3 to 5 days. Not that it's anybody's fault, but I'm just trying to gauge, because somebody's paying for that. I'm trying to gauge where they're staying mostly during that wait period.
Yes, most of the time the individuals are sitting in the ERs or in jails waiting to come in. Now there's a few that might sit at the crisis center, but most of the time it's going to be at a hospital. We've had some hospitals that we've worked with that might have people sitting in their ER, but the wait might be a little long. So they might move them to an actual observation or off the observation bed room to an actual floor.
Right. Yeah. So they're taking up space in the ER as well as staffing, and all of that is what I was trying to understand. My last question is trends. Do you have an idea, or when you have some time, you might have it somewhere, I'm not sure. What trends are you seeing for the past 5 years as far as occupancy, wait lists, and what are the primary diagnosis for individuals coming in? That's a lot. You don't have to answer that right now, but I would like to know at some future time. Thank you.
I can tell you one that stood out to myself out at Larned, and something I brought up specifically for the PSP program is we are seeing younger and younger individuals come with higher moderate to severe mental health already going on. I used to work in child welfare before I came over to the psychiatric hospital, and I am seeing some of the children that I worked with through St. Francis and services age out of the system and now are screening into our state hospital at 18, 21, 24, and are still struggling with mental health challenges. So that's something that's kind of popped out to me and concerned me, of just seeing individuals come in so young and have such severe mental health challenges, and knowing they have a very long life to live. So trying to find them the supports and help them with the stability is can be very challenging. And a lot of those individuals don't always have the best support. So that's something that stood out to me specifically. And then also on the SSP side of it, I mean, just the medication compliance, and that is a huge key piece to achieving competency is being able to help those individuals comply with medication to help with the psychosis, the schizoaffective, schizophrenia type diagnosis. So that's something that we've seen increasingly challenging is getting individuals to comply, and then upon release, having them hoping that they stabilize and remain compliant in the jails before they're able to proceed with their criminal procedures. So that's a couple of things that's been, recently discussed and brought up in some of our leadership meetings.
And one of the things that I tend to notice, and probably because I did do all the discharge planning previously in the past, is that we are having less and less facilities for individuals to discharge to. There are not a lot of group homes anymore. We have limited availability for the nursing facilities for mental health. So a lot of times we don't have a place to discharge an individual who needs that continued support. So they might not need the level of a state psychiatric facility, but they need that transition or that step down program before they go into independent living. And a lot of times that's not there, or they don't have those wraparound services to be successful in the community.
Thank you. I have not been to either one of your facilities, and I would really love to be able to come out and tour what you guys are doing. Is that possible? That if anybody on this advisory panel would like to go up and just kind of see what you guys do and just in person. I know that helps me a lot because I'm a very visual learner. So if I can see it in action, it helps me get a better understanding of what you're seeing and the challenges you're facing.
Yes, please. Just give either one of us a call, and we will help arrange that. I'm a visual learner as well, so I completely understand needing to see it firsthand.
Thank you so much.
We'd love to have you.
Joan?
I have a couple. Ashley, when you look at your staffing numbers, I'm just curious, when you have a DARE at 60 beds and 115, is that allocated if you used all 60 beds, or is that where your staffing pattern is currently?
That is currently where it's at.
Okay, so it would take more if all your beds were full.
Correct.
Okay, I'm just trying to get a sense of what a 50-bed facility would look like locally, and I'm sure everybody else is too. But my other question is, are you using any long-acting injectables at the state hospitals?
Yes, we do.
Okay. That's a shift then. Good.
One of the issues is we don't have the patients long enough to be able to establish that as a treatment regimen. But if I think, and they'll correct me, but if we know that they've been on a long acting injectable before they came to us, then we try to restore them to the treatment they were on.
Yeah, I'm just thinking of those younger and younger youth those young adults that you're seeing. The sooner we get them on those, the better their life can be. Thank you.
And we do work really close with the mental health centers and their liaisons to say, okay, they were on, Haldol long acting Decanate. So then we'll continue that here with us. So we work closely with them on that.
Oh, yeah.
So just a quick question, in the data that you had presented in your spreadsheet, it looked like, at least from the numbers in the tables, that 40 or 25 and 21 were coming respectively out of Sedgwick County. As this facility comes online, are you expecting a decrease of that magnitude? And what is the impact to staffing? Do you see staffing moving with the patient population?
That's a great question. I got my crystal ball, darn it.
I don't think I don't think the staff will move with the beds. I think we're looking to grow the overall pie. We've talked about that some. If you just take that 25 or so that come from Sedgwick County, we would just pluck them out of the Osawatomie catchment area and drop them here. That's probably true right until we get to a patient that needs our secure unit or needs something more intensive than we're able to provide here, or there's an aggression issue, we need to get them to Larned. So one of the ways we manage the system that we have is we can administratively transfer between campuses as we need to. So, and that's not everybody of the 25, but so that's a question we've been trying to think through too, of what that number looks like.
Well, and it goes in line with the conversation about, do you need 100 beds versus there is backfill, like I get that, but I was just curious what the thinking was in terms of talent and capacity impact.
And we're still not capturing the SIAs in this mix either.
That's true. It's true. Are there questions for the superintendents? You might hang on for just a couple of minutes in case you have a question down the road. Do you want to move on and have Tim Kaufman give us an update on activities happening in Sedgwick County, and then close with the discussion that we were having about figuring out some public engagement, getting that scheduled and see how we can address that. Thanks, Tim.
Sure. Hi, I'm Tim Kaufman, a Deputy County Manager here at Sedgwick County. I'm responsible for the Division of Public Services. We thought it might be helpful for the panel to have a high-level understanding of the public mental health environment here in Sedgwick County, so that Joan wouldn't have to present to her peer panel members. I'm going to go ahead and cover that, but Joan is responsible for much of the work that I'll talk about today. ComCare is the primary deliverer of outpatient public mental health services here in Sedgwick County. For the next few minutes, I'm going to provide an overview of what ComCare does, how that fits in with the state hospital system and the local hospital system to a degree as well, and then some of the key players in that arena. So we've got a visual that we've used a couple of different times that shows just how complex and how large this system is in our community, and I think probably in other communities as well. But in the center, we've got individuals that need help. We've got a number of different ComCare programs. We do school-based services. We do crisis services, services for adults and children, and we do mobile crisis response. We do a lot of stuff in the community. The 988 call center is relatively new. We do that. And then there are a number of other players in the community as well. We've got local hospital representatives. We've got some of our other partners in the area. There are private practice providers. There is a substance abuse system in the community as well. Much of that is done privately. And then we're starting to get more involved in justice alternatives as well. So lots of different things going on right there. ComCare, as I mentioned, is a key player in the center of this. They deliver community-based services under 3 different licenses and certifications. The most recent is as a CCBHC, or a certified community behavioral health center. And they've had that designation since May of 21. And as a preliminary certification, it is a new approach to community-based mental health care. There are a number of additional requirements and expectations of a CCBHC beyond a CMHC. And they have got their full certification visit coming up in a couple of weeks now. So that's exciting for Joan and her staff as well. Many of the services that you were just described at the hospital level are done in coordination with the CMHCs. Not all of the CMHCs in the state of Kansas, there are 26 of them, have transitioned to that CCBHC level of care. There are still state responsibilities of CMHCs as it relates to hospital admissions. And so much of the work that they do is related to that. And they also serve a couple of different targeted populations through some waivers to make sure there are additional services available. And then ComCare is also a certified substance use treatment provider. Their focus is primarily on those individuals that have both a substance abuse and a mental health need as well. So we're not the largest player in that community, but we certainly serve an important, difficult population to serve there as well. In terms of ComCare and the services that they provide, they have been a CMHC for 60 years, and they serve a full range of ages, young children all the way to adults, again, without regard their ability to pay. This is truly the public mental health safety net in the community. And the work that they do is in coordination with and on behalf of the state of Kansas, particularly KDADS, but also KDHE to a lesser degree. ComCare is the designated mental health and Medicaid authority locally, and we serve adults, children, and crisis serves people of all ages. One of the things that I think makes ComCare incredibly valuable to the community is that we have a very large medication clinic, 19 different prescribers, 8 of those are psychiatrists, and that fills a significant need in our community as well. As a CCBHC, there are a number of new requirements and expectations, but I think in general, the goal of the designation at the federal level for CCBHCs was to expand services, make sure that more services are available to individuals with need. There's a change in the payment model, which with the expectation that result in additional staff and that additional funding be invested into the system. And I think that ComCare is well on their way to making that happen. Today, there are 442 employees at ComCare. there were roughly 350 a year and a half ago, 18 months ago. There's still a 35% vacancy rate for licensed folks, whether that be clinically licensed staff or nursing staff, but much improved in the last year or so. So in term, this is a state hospital. The conversation we have today is a state hospital that will serve adults, but there are youth services. And again, one of the goals is to make sure that individuals don't need that highest level of care. They're able to receive the services that they can at the least restrictive level. And so ComCare has an extensive children's program, and they offer services to kids that are struggling with mental health issues that impact their ability to be successful at school, in the community, or at home. And they do that through case management, medication management, individual and group therapy. The mental health intervention teams are an important addition to the mental health environment for kids. In the last few years, legislature identified this as a program that would be helpful to those children and to the schools. And ComCare was an early pilot program in that area. We are now in 5 different school districts in Sedgwick County, and we have staff that go to probably more than 100 schools within the Sedgwick County area, when we've got staff in and out delivering services where the kids are. So lots of work goes on in the schools in coordination with the schools. We also have a therapeutic early childhood team that gets children ready for kindergarten as well. Some of those kids struggle mightily in daycares and preschool and that sort of thing. And the program is designed to help get them ready for school. In terms of services for adults, this is more the crossover population with the state hospital. ComCare, as I mentioned, does have an addiction treatment service program. Again, the focus is on those individuals co-occurring mental health and substance use disorder. They have an extensive outpatient medication, individual therapy, group therapy services to address mental illness. And then for individuals who've been diagnosed with a severe and persistent mental illness, they're at the greatest risk of hospitalization. They're served through our community support services program. Again, there's medication management, there's individual and group therapy, there's case management, there are specialized services that go along with some of the waivers. But again, the effort is always to help individuals overcome some of the symptoms of their mental illness that would allow them to be more successful in the community. And ComCare has a very extensive crisis program as well. And the 988 call center and the local call center are available 24 hours a day, 7 days a week. There are staff available so they can be seen on a walk-in basis 24 hours a day, 7 days a week. And crisis staff do about 75% of the competency to stand trial evaluations in Sedgwick County, individuals that are in detention facility here. And that's to ensure that they can effectively participate in their legal process. The crisis program serves the full gamut of the community. They handle about 60,000 calls a year. Then there's those walk-in folks as well. Mobile crisis is one of the things that we have continued to expand on here locally. And we have a number of different models now. We've got the traditional, the model that's been in place for the longest is staff dispatch from the crisis program to the community and trying to assist folks in the community. We have a co-responder model that includes law enforcement and a paramedic, and we are now introducing a new law enforcement alternative responder program. So we've just partnered up with the Wichita Police Department, and we will have staff that will dispatch in the place of law enforcement based on a set of criteria that our 911 folks will hear. And again, try and free up those resources to more appropriately address criminal activity rather than what may be a behavioral health the crisis in the community. And then we've got a continuum of services available to help people not go to the state hospital. We've got a community crisis center that includes a 23-hour observation beds. In that facility, we're co-located with Substance Abuse Center of Kansas. They offer sobering and detox services on site. So anyone can bring an individual, self-identify, or law enforcement may bring someone in that needs services, and it doesn't matter if it's a substance use or a mental health crisis that they're in, right? We'll be able to address their needs in that location at that time. We also have some longer stay treatment options as well. The crisis stabilization unit offers about a 72-hour stay. Morris Place, try to target 4 to 14 days. There are folks that may stay longer. As again, an alternative to the state hospital or hospital level services. Much of the work that crisis and the other programs at ComCare do is again to keep people from having to need that level of care that's offered at a state hospital. One of the big responsibilities and roles for the crisis program is to do assessments and determine whether or not people are appropriate for that higher level of care. Those assessments occur through our community crisis center for individuals who present there, or they may be called in. The local hospital may call for an assessment and evaluation to determine if they're at the right level of care. And we also receive a number of requests for mobile response. And so we will do evaluations for individuals in the community. That call may come from a family member or a loved one. It may come from law enforcement. It may come from the community, again, family members, that sort of thing. But we will do those evaluations either at the location, our location, or out in the community where that person may be. And 988 is the primary conduit for making the ComCare aware of that need for that evaluation. And then if a determination is made that involuntary hospitalization is the appropriate level of care, then staff start to look at hospital options, whether it be state hospital or an SIA placement. Again, the effort here locally is to try and make sure that whenever possible, folks are treated in a least restrictive environment. Most screens that ComCare staff do not result in an inpatient designation or an involuntary hospitalization. There are a number of different alternatives here in the community that ComCare staff utilize, including their crisis observation and stabilization units. Via Christi St. Joe campus has a patient observation unit that's very helpful as well. And then SAC offers detox options. And then ComCare staff also work with family members in the community, help people maintain in the community rather than going to hospital. Through October, 88% of the assessments that have resulted in diversion rather than state hospital placement. And I think that's a critical piece of information for you to think about. Again, when we're talking about what's the right size of a facility, is it 50, is it 100, is it larger than that? Again, remember that ComCare and other communities across the state are doing everything that they can to help people maintain in the community rather than in the hospital. Most of the folks that are screened for services are not known to ComCare or report receiving mental health treatment from another provider. So that's another interesting component of this. Oftentimes people have that first experience, and then our staff work with them to maybe address those needs in the community rather than at the hospital level. For those that do need an involuntary admission to the hospital, the ComCare staff will work with the courts to make that happen. Again, Mr. Bennett's staff as well. Hospital liaison staff then begin working immediately with state hospital staff to bring those folks home. ComCare has a weekly schedule where they're going to Osawatomie to bring folks home that are appropriate. And the goal then is to have everyone have their next community-based appointment within 72 hours. And either at ComCare or with an existing, if they have an existing treatment provider. And another priority is to make sure that we're not discharged, that the hospital discharge doesn't involve a discharge to homelessness for individuals. And so ComCare and their staff partner with a lot of different people. Many of them are here in this room today, but ComCare has some affiliate providers, Mental Health Association, DECA, and Pyxis help deliver those community-based services. Essentially, Via Christi plays a critical role with voluntary hospital beds and the SIA beds and their patient observation unit. The public health safety net clinics include the FQHCs and the lookalikes. And then ComCare also has a specific relationship with Grace Med and a co-location project on North Amidon, where we've got staff that are available to meet anyone's physical health needs or their mental health needs in the same setting. Substance Abuse Center of Kansas, as I mentioned, is a critical partner in the community crisis center that we have. There are private practice and primary care providers, over 200 behavioral health primary care providers in the community. And then we also work with a number of housing and homelessness service providers. ComCare is in the process of doing the work that needs to be done. We have a capital improvement project to expand the community crisis center. We will bring all of those services under one roof, and we will be able to manage staff a little bit better that way and make a better treatment service option for those individuals that we're working with. And that is on about the same timeline as the state hospital is. So hopefully they'll all get done around the same time. And finally, in terms of partnerships within Sedgwick County, because ComCare is one of the few CMHC, CCBHCs that's attached to local government, we have some opportunities to do some additional partnership here. And so we partner within the Division of Health and Human Services. We've got Aging and Disability, our Department of Aging and Disability, they are the ADRC. And so there's a lot of senior work that happens collaboratively between ComCare and Department on Aging. The health department here at Sedgwick County, there's a crossover, particularly with our child and maternal health program. And then we work closely with emergency communications, including we're now piloting trained ComCare staff to be located inside the 911 call center and to relieve some of those calls from those call takers and more appropriately address that behavioral health need that comes across the 911 line. And then we work routinely and regularly with EMS and all the public safety agencies and organizations within Sedgwick County as well. Talked about all of this to provide a little bit of foundational information. I mentioned the number of staff that ComCare has. Talked a little bit about the workforce shortages that I think anybody that's working in the community in this area, we have some concerns about that as well. But again, it's really a partnership between the community and the state hospitals across the state that I think that we do a particularly good job trying to help people stay within the community and again, serve them at that least restrictive level. So I'd be happy to answer any questions you may have.
Just a quick question. Do you have co-responders that work with your law enforcement, which are specifically, I saw something about working with getting somebody trained, but do you have mental health certified staff that go out with police officers and so they can figure out if they have to go to jail or go to a crisis center or do an evaluation, whatever that might be?
We do. We have a program where called ICT1, which is a co-responder model where it's a law enforcement officer, a paramedic, and then a ComCare staff person is going to be out. And then we're expanding in our mobile crisis options. And now we're partnering with Wichita Police Department to dispatch our staff to calls with the recognition that we may be bringing those law enforcement people back to that scene as well. after that determination is made, who's the right person to serve that individual.
And we will often go out and meet the law enforcement out there if they're on scene and need our support. We meet them frequently.
And can you explain the difference between the ICT one model versus just the CommCare mobile crisis at the same time?
Sure. So mobile crisis staff are dispatched from the community crisis center, and they are going to be working closely with the call center staff who say, someone's called in and they need a response it would be better for them to be served in the community rather than have someone bring them into the crisis center. So we've got staff that do that without law enforcement assistance.
Questions for Tim? He's frequently at these meetings, so you have other opportunities. Well, and you all work with them most days, so you have other opportunities to ask him questions. Thanks for that, Tim. Since our time is short, maybe what I would like to focus on in our last couple minutes is the timing of a public input session focused on the location. So what I heard from the discussion before, I didn't hear anybody think it was a bad idea. So I'll assume that we want to have some kind of a open forum town hall meeting around the location of the proposed hospital. Looks like it would have to be between November 11th and the end of that week, given when the proposals will be in, with the county staff and the KDAD staff have some time to review them, and then have something to present that would be either a refined version or clarified so it doesn't interfere with the bidding process. I meant December. I apologize if I said November. In December, so that week is kind of critical given the timing of when we get the proposals and when the county commissioners need to take some action given the timeline that we have. I don't know that we have enough time here to kind of put more parameters around that, and I think we have some homework to do on what's possible. That certainly we'll share with the whole group, but District Attorney Bennett made a good suggestion about maybe having a sub panel. This is an appropriate place for maybe a sub panel to be appointed to help coordinate that activity. We'll certainly have our partners with Greenbush available to help with that as well. Are there any other, I guess the two parameters I'm trying to establish are, number one, that we want to have a session, and it's got to be that week of the 11th. Any disagreement or something I'm missing around those two things? I won't put you on the spot right now with 4 minutes left to go of if you want to serve on that panel, but if you can let me know by email or give me a call if you've got an interest in that. I do feel like I need to keep the whole panel informed about, here's what we know about the process, here's what we know about restrictions that we have, so we kind of all know what the parameters are. But then I do think there's probably some more detailed work that a subgroup would make some sense to be able to dig into that with more detail.
My follow up to that is because we don't meet again until the 11th. Procedurally, is this something we need to approve? If so, do we need to have a Zoom meeting to approve the proposal submitted by the subcommittee? A subcommittee presupposes that then this body endorses what the subcommittee does, or do they? Am I making this too complicated?
What are others' thoughts about having a meeting before we meet on the 11th to approve a plan?
I just think you have some natural insights, having been involved with the KVC build and what worked there and what didn't work, quite frankly.
So, and I'm thinking also of my experience on the Justice Reform Commission, that we did lots and lots of public hearings. And I guess my suggestion is, rather than have people show up here for a live meeting that will essentially be to call one vote, there's nothing that says we couldn't do a Zoom. And I would suggest, so we're clear, we know what our parameters are. That ought to probably be, I'm looking at my calendar here, today's the 6th. We need to probably have that blessed by the end of next week, by the 17th, so that gives the county, and I say the county, but I don't know who else would take this on, the ability to then promulgate the notice and whatnot about this public hearing. Starting the week of the 20th, that would give them 3-4 weeks. That if that's too quick a turnaround, then I think at the very latest, we would want to vote on this by the week of the 20th of that Monday, Tuesday, Wednesday before Thanksgiving, so that would give county staff time enough to get this out. But if you're asking me, my proposal is that we set a Zoom for lunch on the 17th to call one question, and that is to endorse whatever plan has been put together. That gives us the balance of this week, which is a 4-day work week, because Friday, I believe, is courthouse is shut down. Most county agencies are, and then all of next week to get this ironed out. If that's too quick a turnaround, let me know. But
I think that's a good idea, having a quick meeting. My other suggestion is, I don't know how Sedgwick County, when they come out the most, but I suggest an evening meeting. I think that's when most people get off work, but I'm not sure what other rules you all follow. So
late afternoon, evenings are typically when we do these sort of things. And, so we don't get the cart before the horse in terms of where. It would be nice if we knew the 3 or 4 places within the county, and we could go out to those places. That's not probably feasible here. So I'd suggest, I'll just throw it out there. This is probably going to be either at something 4-H building or at Hughes Metroplex. Those are places that the county has had an established history of having public meetings. Century 2 is great, but there's probably a cost and I'm not sure we can get that turnaround fast enough. But Hughes is usually got at least one room available for something like this. So again, I'm not putting any vote on the table. I'm just trying to focus our attention.
But the suggestion is by Friday, the 17th, there'd be a proposal about what this public input session would look like, where it is, timing.
So we could give those folks time and approval to go do it, to go get it set up.
Objection to that being a time frame, and if we can get together on a Zoom over the lunch hour, or we can do it by an email vote, I think that's an appropriate procedure as well.
As long as email vote, I think is okay, as long as it's for open meetings. I'll defer to county counselor, but you'd have to comply with open meetings to do that.
Okay.
So I understand this is fine. I'm just talking about, so we're gonna have a public meeting, and it's going to be about placing a mental health hospital in either northern Sedgwick County or western Sedgwick County or eastern, or
sure.
And that's it.
Yeah, I don't think you're in a position.
I get that, but that just seems.
And what concerns people would have, I mean, the surveys capturing some of that would be another place that if people said, it absolutely shouldn't be next to a school.
People are going to show up and be mad. And they're going to, where's it going to be? What's it going to cost? I want to know. And you're going to go, I can't tell you. I don't know yet. And that's not being coy. It's true. We don't know. But because we're on such a fast turnaround, if we had 3 or 4 years to do this, then we wouldn't do it like this. But since we don't, for the county commission to have at least a intelligent conversation about this, I think they're going to, if I was on board of county, I wouldn't vote on the damn thing until at least I knew the community had been heard. And so I would suggest we can at least say, where do you not want it? What if it went here? What if just break the county down into quadrants? What if it went someplace? And, we're not, again, being coy, and to the extent that we can be more specific, we got it broken down to these 3 pairs. Okay, we can do that. But we're at least giving people a chance to be heard. It's not ideal, but it's better than us making a decision in a vacuum.
And part of that proposal that we'll bring for the 17th would include we'll figure out what we can share between now and then. And there may be, I don't think we're missing a lot, but there may be something else we can figure out of what can we share with the public at that time. It's not violating some part of the bid process. It may not be more than, here's a quadrant of the county, pick which corner you want it in. I don't know, but that gives us a little more time to work on that and have that included in that proposal.
And I think that's part of the charge is to get public input on several of these things and take them back for the recommendation and be thorough about it, at least vetted.
Don't see any objection to that. Saw several heads shake. So we'll proceed with that as the direction. If you have other particular thoughts, feel free to let let me know and we'll incorporate that. If you'd like to help work on an early version of what this document, I'm not quite sure what this proposal will look like, just let me know that as well. And we'll get something on the calendar for the probably around noon hour on the 17th as a way to convene and have a central location for that. Okay. Any other questions or last thoughts? So at our December meeting, we've got a couple of things we have to accomplish. We have to review or at least put some parameters around the report to the legislature and the governor. We'll try to have a draft, as much of that as we can write out based on the survey results. There's other stuff we're going to get between when we meet on the 11th and in January, but we'll at least get that framed out so you can see what the first report would look like.
I think that
we'll know a little bit more about the location as well, but
I think that report's going to be somewhat dated by the time the legislature gets it, but it's going to be something that says, this is what we're going to recommend to the BOCC. By the time the legislature sees it, the BOCC will have already voted.
Yeah.
But at least we're being transparent along the steps of the way.
And if the panel wanted to include an early recommendation that we consider funding the full 100 bed count or 75 or 150 or whatever, we have an opportunity to do that where it fits into the legislative cycle a little bit late, but still with plenty of time for the legislature to consider that.
Is it possible to get these timelines like nailed down? I was trying to write feverishly on some of these notes, and it seems like if there's any opportunity to do things in parallel, to push things together that can glean information to come to recommendation and or some sort of finality of 2 or 3 options, anything that we can push together in a timeline might helpful. I'm having a hard time visualizing it, but yet the deadlines seem to be pretty apparent. I just don't know where those opportunities might be.
No, that's a good request, and we'll work on that. We're going to talk right after this with the county folks about some of these other milestones and what that would look like as a parallel discussion, because we won't hit the timelines otherwise. Okay. Well, a productive day. I'm as scared as I was last time after we met. So in case anybody's thinking there's a lot of wandering around, not seeing any objection of adjourning, we'll stand adjourned. Thanks.